Well, good morning. Jeff McCowage here. I'm a paediatric oncologist at the Children's Hospital at Westmead. This is Children's Hospital, the biggest children's hospital. It's in Sydney, Australia, and I'm a paediatric oncologist. And today I want to take you through an abstract that was presented at the American Society of Clinical Oncology meeting held in Chicago in June of this year 2025. So what I'll do, I'll share my screen so you can get rid of me and we'll go to my desktop. And here's the cricket team. By the way, if you look up here, that's my name, Jeff McCowage. All right, now what I want you to do is, if you do this, if you go to ASCO.org, American Society of Clinical Oncology, and if you go to meetings, abstracts and presentations, and then what you do is you type in here where it says search for abstracts, you go ASCO. Oops, I've got to click on it. ASCO 2025 neuroblastoma return. And it comes back with the 13 publications from this meeting this year. And I want to point out early on that you'll notice I haven't signed into my ASCO account. So I'm not showing you the access to the paper that you get by being a paid member. This is free. It's out there on the ASCO website and made available to you. And so I hope they don't mind if I just take people through what they've already put out there in, I guess, plain English and with a bit of editorial commentary. So today I want to look at this paper, Late Effects in High-Risk Neuroblastoma Survivors Who Received MIBG Therapy. And I'll explain it all. And here's the first author. And by the way, this was a poster presentation. They have these things, see over here, called poster sessions at big conferences. You have oral sessions, where someone gets up with their PowerPoint and talks and presents their data. And then you have these poster sessions where they have this huge, great room with row after row of posters on walls. They're big, huge posters, big things like this that talk about the background to the project and what they did and then all the results and their comments. And it's quite a good thing. Some people don't like giving oral talks. Uh, it's also a good place to network, is cruising the posters and you get to stop and talk with the authors, and it's quite good. But here's the first author, Prerna Kumar from Peoria. And here's the rest of the authors. And these are some really very senior people in pediatric oncology, particularly from the United States, uh, real heavy hitters. And it's describing all the hospitals they all come from. But down here, you'll see that it's funded by the Children's Oncology Group. And that's the big American government funded, largely pediatric cancer research group that takes in multiple centres in the United States and in Australia and Canada and elsewhere. And it's also funded by this group, St. Baldrick's Foundation. They're a charity. And I don't know who these two are, but St. Baldrick's, their thing, of course, is I think there might be an actual St. Baldrick, but one of the things they do at their fundraisers is people volunteer to have their hair shaved off and become bald, and for a donation to St. Baldrick's. That's their thing. And they're a great supporter of childhood cancer too. And all right, now let's just start on this. First off, they tell you about high dose MIBG. Now, MIBG is one of these radio labeled isotopes, which we use for doing MIBG scans. That's uh, to identify where neuroblastoma is in the body. But you can also give a very high dose of MIBG that'll be taken up by the tumor and hopefully be toxic to the tumor and kill the tumor. Now, by the way, I've actually done a podcast episode on this If you look up my podcast, Understanding Childhood Cancer with Dr. Jeff, in podcasts, there's about 70 or 80. And there's one from August 6, 2016, that tells you about high dose MIBG as treatment. And what I've said there wouldn't have changed a whole lot as far as how you give the treatment and so on. But what's changed is its place in treatment, an emerging place as more experience and studies are done. So back to anyway, so these authors point out that people have been treated for high-risk neuroblastoma with high-dose MIBG, either just given alone or combined with other treatments. And we all know that. But this is a paper that talks about in people who survive their cancer, their neuroblastoma, if you look at them years later, are there any long-term side effects from the MIBG? Does it bring some long-term, like permanent type side effects that you don't get from the chemotherapy and the immunotherapy and everything else? The treatment of high-risk neuroblastoma is very intensive, very strong chemotherapies and transplants and antibody therapies and major surgeries. These are all part of our treatment for high-risk neuroblastoma, like stage 4 type older children neuroblastoma or NMIC amplified neuroblastoma. So this study was to describe those people who had high-dose MIBG and see if it was associated with long-term side effects, things like growth impairment, second malignancies, thyroid cancer, other things. All right. So then they have the methods and they tell you what they did. And if you can access the poster by having a registration for the meeting, you can look at the whole poster and read all of this. But I'm just showing you what ASCO makes available freely here. And I hope they don't mind because ASCO holds the copyright and the Children's Oncology Group are authors, and I'm a member of the Children's Oncology Group. So I hope they don't mind. But I don't think they should. All right. So what they did, they found children who'd been treated for high-risk neuroblastoma after 2000 and have survived their cancer, and it's at least 5 years from diagnosis. And then they identified within their bigger group patients who had high-dose MIBG as part of their treatment. And they're called the cases here. So they've had high-risk neuroblastoma, they've had all the treatment, but part of the treatment was high-dose MIBG. And it's 5 years later, and they've survived their cancer. And so then they've gone and looked at them for any long-term side effects. And then what they did, they found some matching patients who were the same age as these patients and who also had high-risk neuroblastoma and who also have survived their cancer and it's 5 years later, but they didn't get high-dose MIBG. So they will have had chemotherapy and surgery probably, and maybe radiotherapy and maybe antibody therapy, dinutuximab, in that whole program, but they didn't have the high-dose MIBG. So now you've got some patients who've had it and who haven't, and everything else about them is, hopefully pretty similar. And so the aim here is to work out, well, if you just look at the ones that got the high-dose MIBG, did that contribute to any long-term side effects that the patients who didn't get high-dose MIBG don't have? All right, and that's what they've done. And they've got two non-MIBG patients for every one MIBG patient. And look at that, they did p-values with the Holm-Bonferroni approach. That's why you have a high-flying statistician in the group. See that Wendy London there? I don't know if there are other statisticians, but Wendy London is a long-time pediatric cancer statistician who knows everything. Right. And so she will understand the Holm-Bonferroni approach, but I sure don't. All right. So then they come to their results. And they found 32 patients who had the high-dose MIBG treatment. And by the way, those 32, 17 of them had it because they had had a relapse or because of what's called refractory disease, meaning they were having treatment, but the cancer wasn't responding adequately. or they'd had treatment and then had a relapse. So 17 had their high-dose MIBG for a relapse or a refractory disease, and so presumably the other 15 had high-dose MIBG incorporated into the initial program of treatment, I presume. The poster will tell us this, but we don't have it. All right. Anyway, 32 patients had high-dose MIBG, and it's 5 years later. And they had all the other chemotherapy, etc., I expect. Okay. Now, their average age was 5.1 years at the time of the treatment. 56% were male. And it goes on to describe an adrenal primary in the abdomen in 62%, bone metastases in 72%, bone marrow 63%. These are fairly sort of typical, I think, for high-risk neuroblastoma. And now we get to the real results. So what about thyroid toxicity? See, MIBG, the I stands for iodine. And the thyroid gland here in your neck sort of controls your metabolic rate. The thyroid gland uh, uses iodine to make thyroid hormone. So the thyroid gland is always sucking up iodine from your bloodstream. So when you give high-dose MIBG, you have to block the thyroid. But still, it's of interest. Does the MIBG get into the thyroid gland and do something bad to it, like hypo meaning underactive, or hyperthyroidism, overactive, or nodules in the thyroid, right? And this is an important thing to work out. So what they say is that 10 of the 32 had some sort of thyroid toxicity. And the poster will tell you what it is, underactive or overactive or nodules in the thyroid. And nodules are important in the thyroid because sometimes they're just benign nodules. They're not cancerous or anything, but you have to keep a close eye on nodules, and sometimes you do have to take them out, make sure they're not cancer. So that's an important question. All right. 10 out of 32 had something with the thyroid gland. And then remember, they've got the control patients who had everything else, but not the MIBG. So, and they have 63 of them. Remember, it was about 2 to 1. Just they picked two controls for every case. So they're saying 11 out of 63 of the controls had a thyroid problem. So even without high-dose MIBG, 11 out of 63 patients have a thyroid problem of some sort. Now, how severe, you need to look at the poster and work all that out. Um, Now, why are they getting thyroid problems? Well, remember, they will have had a lot of MIBG scans. They mightn't have had the high-dose MIBG as a treatment, but they probably have had MIBG scans to track their neuroblastoma and look for it and so on. Now, maybe that exposure to MIBG could be looked at. Does that contribute to thyroid toxicity later on? Maybe someone will have looked at this, you can be sure already. But anyway, now they're saying that that's broadly similar between the two groups, 10 out of 32 versus 11 out of 63. I suppose that's a little bit higher in the MIBG treated patients if you just do the raw numbers. But the statisticians have looked at this and they don't think that that's a significant difference. They're saying it's similar in both groups here. Next, what about getting a second malignancy, right? So you survive the neuroblastoma only to go on and get another form of cancer later on. Tragic event if it happens. So in the people who had the high-dose MIBG, they're saying 1 out of 32 had developed a second malignancy. And in the group that didn't, 4 out of 64 got a second malignancy, a subsequent malignancy, and what malignancy it was will be in the poster, whether it was a leukemia or whether it was some other solid type tumor. All of that will be in the poster, but that's not a lot different between the two groups. Growth failure is something we always have to watch out for after we put children through such an exhaustive program of treatment. They've had chemotherapy, bone marrow transplants. They were only young at the time. We always monitoring growth after such treatment. So they say that 35% of the patients, the cases, the patients who had the MIBG, that's 11 out of 31, had some measure of growth failure, compared to 23% or 16 out of 63 of the patients who didn't get high dose MIBG had some sort of growth failure. And that's the sort of thing we're looking out for. And if we start to see someone isn't growing properly, we look at what we can do about it. Some children get given growth hormone treatment. Some need other things corrected medically, but it's not something we just sit and ignore. We look into it and see, well, what can we do about this growth failure? All right. So they're saying that 35% versus 23%. And again, that looks a little bit different, but it's not very different. The statisticians will tell you it's whether it's a sort of difference that might just occur by chance and not be a real difference, given these are relatively small numbers, right? It's not like we've got thousands of patients in each arm and statistical power. Okay. And then they go on to say that the other major organ toxicities were also similar, no significant difference. So here's what they have concluded, that in survivors of high-risk neuroblastoma, they're saying that the burden of late toxicities in people who had high-dose MIBG as a treatment is about similar to those who had all the other treatment without high-dose MIBG. And that's what they're saying. They're saying it appears similar. And that's a good sort of cautious conclusion to this. And those more numbers emerge and longer term follow-up, there'll be more information to come. But they're saying this is pretty important as you look after patients years after treatment. And as you think, well, should we be using high-dose MIBG or not? Well, if you found that it had a whole lot of very terrible long-term side effects, that might steer you towards other treatments. But on the basis of this, they're not seeing a terrible difference. They're not seeing the long-term side effects are hugely different. And I guess that means that you might think it's reasonable to incorporate high-dose MIBG into treatment if it works and if it's judged an important thing to include. So that's their story. Pretty good paper to extract all of that from multiple centres across Australia, Canada, the United States, all over the place, and to work all of that out. It's a huge body of work to do this sort of thing. This will have been a big job, and it's yeah. Now, and of course, down here you'll see it's copyrighted to ASCO, licensing available upon request. Now, I have emailed them to say, do you mind me making these YouTubes? They haven't got back to me yet, but I hope it's all right. I'm acknowledging them. I haven't signed in. This is stuff that's all out there anyway. And there it is on the left-hand side, the poster session this year. Now, by the way, if you then hit back, there's the other 13. You can have a look at all of those if you want. I've done, I did a video on a YouTube on this one, on dinutuximab as well. And I hope to get to one on this DFMO one down here, this one, in time. But for now, I will stop there. Now, it takes a bit of time to put these videos together. It'd be good to hear if anyone actually thinks they're useful. Um, so do let me know if this is a useful thing to be doing or if I'm wasting my time. Thanks a lot. Bye-bye.